the spinal cord. They cross over immediately. The dorsal column did not cross until they get to the medulla. But the spinothalamic tract cross over immediately and they ascend. That's one neuron, that second order neuron is the same neuron that goes all the way up to the thalamus and then finally to the sensory cortex. So now we trace the information flow from the receptor up the spinal cord to the sensory cortex. Right? Now, from the sensory cortex, the brain, so the sensory cortex is right here in the blue, right? Now the information is now integrated, translated, and a response is formulated. And that response is formulated and communicated to the motor cortex, the red zone, right? In the frontal lobe, to the motor cortex. And from that motor cortex, the command in terms of neuronal codes is now put into motor neurons. See, this homunculus is a representation of how much of the sensory cortex is dedicated to specific parts of the body. So which part of the body has the largest representation? The face, exactly. Right? The face. Okay? And which part of the has the smallest area? The genitalia. That's why there is nothing cortical about sex. It's a very animal thing. That's why I don't understand why we put too much emphasis on it. It's the least important part of our being. But it's what some people will kill for. Right? But that is beside the point. So you see, all the sensory information ends up in this sensory cortex. And the response is developed in the motor cortex. And the information now has to go from the motor cortex to the effector. Now, from this motor cortex, the neurons now start coming down. You see this convergence of the neurons into this tract. Up here is what is called the corona radiata. It's not on that diagram, but it's called. You see, they come from all the areas and all the neurons carrying these motor commands. They come from the motor cortex like a fan and they condense into this tract. Some of them are going to end up in the brainstem if they are going to the face, right? Some of them are going to continue down into the spinal cord. Because they carry motor information, they are called motor neurons. Okay? They end either in the brainstem or in the spinal cord. So it is one neuron that carries the information from the brain either to the brainstem or to the spinal cord. If it carries the information to the brainstem, it is called a corticobulbar tract. If it carries the information to the spinal cord, it is called a corticospinal tract. See what the corticobulbar tract does. Once it gets to the bulb in the brainstem, it crosses to the other side. Okay? When it crosses to the other side, it gives its motor command to another neuron that now exits the brainstem. That other neuron that carries the information from the brainstem to the effector is now called the lower motor neuron. Okay? So, the cell bodies of the upper motor neurons are in the motor cortex. They end either at the brainstem or at the spinal cord. Now, from the spinal cord, a lower motor neuron emerges carrying that information. Right? So one important point I want you to be clear on here is sensory information will get to this sensory cortex through 3 other neurons, first order, second order, third order. But motor information will come down through an upper and a lower motor neuron. Okay? Good. Now, the corticospinal tract, they don't cross at the spinal level, they cross at the lower medulla. So you see all the corticospinal tracts from the motor cortex, they keep coming down. Once they get to the lower medulla, they cross over to the opposite side. Okay? This is so important because this crossing over and different levels, it's really what determines the way patients present. When they have strokes, they have brain tumor, they have whatever is going on. It's extremely important that you understand this. Okay? So the corticospinal tract, which is a sensory tract, it crosses over at the spinal level, right? The dorsal column, which is a sensory tract, ascends on the same side, crosses over at the upper medulla, right? Because nuclei, the fasciculus, cuneatus, and gracilis are nuclei in the upper medulla. But the corticospinal, because they're coming from the cortex to go to the spinal cord, they cross over at the lower medulla. So both the sensory and the spine and the motor tracts, they cross in the medulla. The sensory tract cross at the upper medulla, the motor tract cross at the lower medulla. Very important that you make that distinction. Okay? Excellent. We didn't go through this detail the last time. So you see, now, this is the spinal cord. All your upper motor neurons, they end right here. Now the lower motor neurons take the information and they leave. Right? And of course, they leave through the ventral roots. Right? Both somatic motor and autonomic information, they leave. The ones that are going to the body, they continue in the spinal nerve. They develop into the dorsal and the ventral root to supply the back and the front of the body. The ones that are carrying autonomic information, what they do, they exit the spinal nerve to make connection with another neuron in the sympathetic ganglion. Right? So they come out, make connection with the sympathetic ganglion. If the ganglion is farther away, they will just continue traveling on until they make connection. What I want you to pay attention to here is that once they make connection with the sympathetic ganglion, the third neuron for the autonomic nervous system then arises from there and connects again with the spinal nerve and carries the information to distal organs like sweat glands and all this other stuff that are far away. Okay? You see the sympathetic preganglionic neuron that leaves the spinal cord, it is a myelinated fiber. Okay? It is a myelinated fiber because it's coming from the spinal cord. It is myelinated. It is called the white ramus. It is the preganglionic. It's the one that leaves the spinal cord that goes to the sympathetic ganglion. So because it's on its way to the ganglion, it is called preganglionic. Right? And because it's myelinated, it is called the white ramus. The one that leaves the sympathetic ganglion to connect back with the spinal nerve and travel with it is an unmyelinated neuron. because it leaves the ganglion, it is called postganglionic. And because it is not myelinated, it looks gray. It is called gray ramus. Together, they are referred to as the rami communicantes. Okay, so the gray ramus and the white ramus together make up what is called the communicantes. They are just responsible for the autonomic impulses. Okay? Good. Are we good? We didn't go into all this the last time. I thought it's important because I was looking at the exam. I'm like, I can't rely on what somebody else taught you for my own exam. I have to make sure I cover it. So you see what I just showed you in very fine diagram is what this picture is showing you in the way it looks. This is the way you saw it in anatomy, if you remember. You saw the spinal cord, and you saw the nerves, and the dorsal ganglion, the ventral, and then you saw the sympathetic trunk, because the chains, the sympathetic ganglia, they connect themselves together, and they lie right next to the vertebral column, right? So basically, a spinal nerve is a mixed nerve. It carries both motor and sensory and autonomic fibers, and there are 31 pairs of spinal nerves on each side of the vertebral column. Okay? Now, it turns out that yes, even though there are 31 pairs, the sympathetic preganglionic neurons are only carried in spinal nerves T1 to L2. That is why, remember, in pharmacology, we say the sympathetic nervous system is carried in T1 to L2. Okay? Those are the preganglionic neurons. They carry between T1 and L2. Alright? Now, for the trunk, chest and abdomen, the spinal nerves, they travel solo and supply their areas. But for the extremities, they start doing all kind of crazy stuff. They start forming plexuses, combining and separating, and then they now supply the extremities. This, Katie will talk to you more about. We'll do some of it, but right now all I need you to know is that the spinal nerves that supply the extremities, they don't supply the extremities as single nerves. They supply them in plexuses and complexes. So we have the cervical plexus, the brachial plexus, you have the lumbosacral plexus. A plexus is a combination of spinal nerves. They come together and then they redivide in specific ways. And that is why you notice we have different nerve roots for the different reflexes, right? C4, C5, knee jerk, L2, 3, 4, all the stuff that you do in physical diagnosis. All right? Good. So, now, what is the implication of the fact that the sympathetic preganglionic neurons are carried only between T1 and L2? That has implication, because the tear gland, they need to get autonomic innervation. They are in the face. How do the preganglionic sympathetic fibers travel to the face? The way they do it is once they come out from the spinal cord, they can do three things. They can sign up to their neuron at the same level. They can travel up and down the chain. So the one that is supposed to supply the face, for instance, will enter into the chain, go up, and then exit at the level of the organ it is destined to supply. Okay, that is why you notice that the sympathetic chain spans the entire length of the spinal cord, even though the nerves it carries only exit from T1 to L2. You got that? Right? So it's like you have the, I think you got it, right? You have the You have a marker here? So it's like you have the vertebral column all the way. You have the vertebral. Thank you. It's like you have the vertebral column, right? From C1 to S, whatever. And then the nerves come out from T1 to L2. This is how they come out. They form this chain. But they don't stay at the level of the chain. The ones that are destined for the face, they go up the chain, right? So the sympathetic chain is longer than it extends beyond the origin of the nerve from the spinal cord, right? So this is why I gave you this, like I tell you, the three things that these preganglionic neurons do. If they are destined for, say, the nipple, comes out right there at T1 and goes straight to the nipple. But if it's destined for the eyes, he has to go up, right? Good. Excellent. So, when they are corticobulbar, the ends at the spinal cord, the lower motor neuron comes off from the brainstem and they go to their different effectors. And the nerves that come off from the brainstem are the ones we call cranial nerves, because they come from the brainstem. They're called cranial nerves. The ones that come off of the spinal cord are called spinal nerves. One thing I want you to realize is that cranial nerves and spinal nerves are both lower motor neurons. Okay? Generally speaking, the corticospinal tract, 100% decusate. But the corticobulbar tract, even though it decusates, a few of the nerves will still leave some of their upper neurons on the other side. So in other words, they have bilateral innervation of lower motor neurons on both sides. Corticospinal tracts, they all cross over at the lower medulla 100% to the opposite side. But the corticobulbar tract, most of them cross over, but a few of them actually divide into two, and they innervate lower motor neurons on both sides of the brainstem. That is the reason facial nerve palsy is often divided into upper and lower motor neuron. That will become clear as we go on. All I need you to know right now is that cranial nerves sometimes have bilateral representation. They all don't cross over. And again, this was just to tell you, whereas spinal nerves are always mixed, cranial nerves are not always mixed. There are cranial nerves that are pure sensory nerves, like the optic nerve. It's a pure sensory nerve, right? Like the olfactory, it's a pure sensory nerve. But a nerve like trigeminal is sensory and motor, right? A nerve like oculomotor is called oculomotor, but it also carries autonomic fibers, right? The parasympathetic preganglionic neurons are carried in cranial nerves and sacral nerves. Specifically, cranial nerve 3, 7, 9, and 10. They are the ones that carry the preganglionic fibers of the parasympathetic nervous system. Okay? So this is just telling you all the cranial nerves from 1 to 12, which ones are pure motor, which ones are pure sensory, and which ones are mixed. Again, I just told you, we said this preganglionic, the sympathetic preganglionic fibers, they come from T1 to L2, but the preganglionic parasympathetic fibers, they follow cranial nerves and the sacral nerves, right? So there is no parasympathetic ganglion chain, no. the parasympathetic ganglions are scattered all over the body, and they are closer to their effector than the sympathetic preganglionic, than the sympathetic ganglia. That is the reason the preganglionic neurons are usually longer in the sympathetic nervous system. I mean, they're shorter in the sympathetic nervous system than in the parasympathetic nervous system. Let me say that again. Because the sympathetic ganglia, they are located next to the spinal cord in the sympathetic ganglia chain. The preganglionic neurons of the sympathetic nervous system are shorter, but the postganglionic neurons are longer. That is the opposite in the parasympathetic. In the parasympathetic, there is no parasympathetic ganglia chain. That doesn't exist. The parasympathetic ganglia are scattered throughout the body closer to the effector. So in the parasympathetic nervous system, the preganglionic neurons are much longer, and the postganglionic neurons are much shorter. So look at some of the examples of the parasympathetic ganglia. The ciliary ganglia, it's very close to the eye, in fact almost in the socket. Pterygopalatine, right there in the roof, closer to the lacrimal gland, right? The optic ganglia is closer to the salivary gland. So all these ganglia of the parasympathetic nervous system are closer to their effector, so their preganglionic neurons tend to be longer, whereas postganglionic neurons tends to be shorter. Okay? Yeah.
Parasympathetic preganglionic only come out of the brainstem and the sacral nerve?
Yes. Yes. The preganglionic parasympathetic neurons only come out, they're carried only in the cranial nerves 3, 7, 9, and 10, and sacral sympathetics. And the sacral nerves, not sympathetic, sacral nerves. Okay? Excellent. So this is what I've been saying all this time. You see, this is the chain, sympathetic, right? That gives the long and short preganglionic and postganglionic neurons. I've already talked about this. This is just a picture of what I just talked about. Okay? Again, this is the two pieces of information together. Sympathetic coming from T1 to L2. Parasympathetic coming from cranial nerves 2, 3, 7, 9, and 10. And the sacral nerves as well. Okay? Right? So, again, this is an overview of what they do. Of course, the parasympathetic, the constrictive pupils, the sympathetic dilated pupils. You remember this, we've talked about this so many times now, right? The parasympathetic is your rest and relax digest system. Your sympathetic is your flight and fright system. So anything that will increase tension, decrease salivation, give you indigestion, constrict your blood vessels, raise your blood pressure, stop your digestion, that is all sympathetic. Things that will give you salivation, sweating, and all those are all parasympathetic. Okay? Now, these nerves, they carry their own blood vessels. The blood vessels that supply the nerves are called vasa nervorum. They are the blood vessels that supply the nerves. You see, the nerves are bundled into fascicles, and the fascicles are then bound together by epineurium, and then several of the fascicles form a nerve. So I don't even know what the point of this is. I feel like it's too detailed. I don't know if you need to know all this, but no knowledge is waste. Just know that there are blood vessels. All I want you to know here is just showing you the complexity of a nerve. It's not as simple as you see it. If you remember in anatomy, when you see the radial nerve, it looks like a simple white cord. It's way more complex than that. It has within that white cord are blood vessels supplying that particular nerve, and they are specifically known as the vasa nervorum. Okay?
Question.
Yeah.
So when you have a stroke and you have ischemia, does it affect those vessels, and that's why the nerves are affected?
As a matter of fact, if it is almost impossible for you to have a stroke within a vessel, so they're so tiny, and there's so many of them, that if you plug one, others will make up. But if you have a disease like syphilis that can affect many of them at the same time, you can actually have that nerve damage. And that's why you get every disease as a long complication of syphilis. Stroke generally happens in the central nervous system. It affects the tracts in the nervous system. Stroke does not have peripheral manifestation in nerves. Even though you might see weakness of the extremity, it is not because the radial or the ulnar nerve is gone. It's because the upper motor neuron responsible for the motor information that is ignited for the radial and ulnar is taken out by the stroke. All right. So, any more questions? I want to use this hour to kind of go through the fun of my next. Are we good? Okay, let's see how good you really are. So tell me, your class, maple skin, ice, Neville, nose, Adam's apple,
C3.
Good. Anyone does not know why any of this is the answer? All right, moving on. So which of the following anatomic structures is a component of the central nervous system?
All of the above.
Which of these is a component of the central nervous system? Are you telling me? You just told me that spinal nerve is part of central nervous system. Is spinal nerve part of central nervous system? No. The spinal cord is. The spinal nerves are spinal, they are peripheral nerves. They originate from the spinal cord, but they are outwards. The central nervous system is made up of the brain and the spinal cord. Period. Cranial nerves are not part of central nervous system. The central nervous system, remember the definition I gave you? The central nervous system consists of the brain and the spinal cord. So, the only thing here is spinal cord. Alright, all of that drives it home. Okay, now how about this one? Which of the following subcortical structure is involved in the regulation of the autonomic nervous system? Hypothalamus, right? The hypothalamus controls the autonomic nervous system as well as the master gland, the pituitary, right? Good. Are we clear? Yes. How about this one? Which of the following anatomic structures is not capitalized a component of the meninges? False cerebri. It divides the brain, it does not cover the brain. Okay, everything else is a brain covering. Duram, fire, and arachnoid. Okay, lepto and what is that? Parkimeninges. Alright. Hey, remember all these things. How about this one? Let's mix it up. Gray Remus. Who said that? Good. Gray Remus is the sympathetic postganglionic neuron, right? White Remus. Exactly. Ventral root. And dorsal root. Spinal nerve. Thank you. Got that? That's it. Which of the following anatomic structures is a component of the brain stem?
All of the above?
Exactly. The midbrain, the medulla oblongata, pons, that is what makes up really the bone, the brain stem. Okay? Which of the following ions is involved in the release of neurotransmitter into the synaptic glands? Okay. How many of you say all of the above? How many of you say calcium? Think about it.
It's all the above,
What is that? Can calcium move on its own?
No, the other
The
one.
calcium channel has to open. What opens the calcium channel? Sodium and potassium depolarizing the membrane, right? Good. So it's all of the above. Okay? The calcium channel has to open for calcium to go in before the vesicles can move and dock, right? If this neuron is not depolarized by sodium and potassium, calcium channel will not open. So therefore that will not happen. So it is all of the above. You got that?
Yes.
Okay. Which of the following autonomic neurons are carried in the thoracolumbar spinal nerves? Preganglionic,
Sympathetic neuron.
preganglionic sympathetic neurons are carried in thoracolumbar segments of the spinal cord. You got that? Excellent. All right, so fine touch, 2-point discrimination. Meissner, crude. Marcos. Joint pressure and proprioception. Pacinian. Nociception. Free nerve ending. Skin pressure. Rufinus. You got that? Which of the following arteries is a component of the circular fluids? Internal carotid. Okay. Anybody confused about this one? Okay. The artery that is not part of the circular fluids is middle cerebral. Okay. Remember, internal carotid comes off, gives us anterior cerebral, posterior communicating, and then continues. The same artery now continues as middle cerebral. It is after the circular willis that middle cerebral is formed. Right? So middle cerebral is not part of circular fluids. Okay? I don't know. Okay, at which of the following central locations do most of the first order neurons of the corticobulbar tract end? Where? These are fibers coming from the cortex and going to the brainstem. Where do they end? The upper motor neurons. They end. Where do they end? Is it brainstem or the spinal cord?
Spinal cord.
Corticobulbar. Where do they end? Brainstem. Corticospinal ends at the spinal cord. Corticobulbar end at the brainstem. And now, do they end on the same side or opposite side? No. They end. They come to their segment and then the same nerve crosses over and then make connection with the lower motor neuron on the opposite side. So technically speaking, where the handshake takes place is on the opposite side. That is where they end. Okay? That is the reason. You remember I showed you the diagram where they come down and they cross. There is an arrow there. Look it up. They cross at their segment and make the handshake with the lower motor neuron. So it's brainstem on the opposite side. Yeah.
So if you would have said where do they switch at, then we can say on the same side.
No. They come down and cross over. I will never ask you switch. They accusate.
Okay.
They come down. When they get to the level at which they're supposed to make connection with their lower motor neurons, they cross over at that level. The same nerve crosses over.
So when would the answer choice A be correct?
It will never be, because I'm asking you where they end.
No, not related to that question, but like if that was the correct answer to something, how would the question be worded?
It will never be, because they could. Okay.
Like it has to start on the same side before.
Okay, I will tell you. Well, I can. If I ask you on what side of the brainstem, on what half of the brainstem do the corticobulbar tract travel?
Okay.
Okay, they travel on the side at which they originate, but they definitely cross to the opposite side, and that is the more important question because that is what determines clinical manifestations, not the other way around. You got it? Excellent. Okay. Which of the following anatomic locations is a site for reabsorption of CSF? Arachnoid villi. And it is formed in the ventricles, right? Good. Excellent. All right. So we're going to match these cerebral lobes with their functions. Language reception,
The temporal.
temporal lobe, right?
Yeah.
Vision,
Occipital.
occipital, consciousness,
Frontal.
consciousness,
Frontal.
brain stem. Which part of the brain stem? The reticular activating system, right? Okay. Speech production, sensation. Parietal. Remember the post-central gyrus, the sensory cortex is part of the parietal lobe, right? And speech production, frontal lobe, the pre-central gyrus, specifically the Broca's area, right? Wernicke's is in the temporal lobe, okay? Okay, so I could have put Broca here and put Wernicke's here, okay, and those will still be the answers. You got that? Excellent. Which of the following structures is not a component of the neural reflex arc? The brain has nothing to do with reflexes. It modulates it, but it's not part of it. Reflex is sensory integration effect. That's it. Okay? Which of the following anatomic locations is this site for production of cerebrospinal fluid? All ventricles form CSF. Alright, the ependymal cells in all the ventricles form CSF, and the arachnoid villi in the arachnoid space reabsorb CSF. Okay? Excellent. Which of the following neurons is best suited for interneuron impulse transmission? The one that just steps aside and passes the information on. Unipolar, right? Unipolar. That's why it has a cell body and one axon, and then that axon divides and just transmits the impulse. It doesn't have anything to do with it. Okay? Are we good? All right, let's mark this. A central collection of axons is called
Nuclei. Nuclei is the central, right?
a central collection of axons is called tract.
Yeah, that's right. Can we go back to the last one? Oh, axons, not. Because you said which is all neuron. Everybody's talking about interneuron impulse, right? But your slide says bipolar. But you said it was unipolar.
Wait. Bipolar. Let's go back. Oh wait, sensory. Bipolar is sensory. That's why we have a dorsal root ganglion. Right? It's unipolar is sensory. That's why we have a dorsal root ganglion. Bipolar is the one that is best suited for. Thank you. Thank you. Oh, thank you. Thank you. So that just saves me a free point in the exam. I would have had to give a free point to everybody. No. It's good to always point out, especially. I mean, it's not,
Get a point. Right, for pointing it out.
yeah, you have a point. You have a point. I didn't say I would give you a point, but then you have a point. Bipolar is the one that is for interneuron impulse. Unipolar is sensory. And multipolar is the one that is really motor, when you have to activate so many parts of the brain to respond when particular impulse. All right, so let's go back. Thank you so much for coming. What else today? All right. Central collection of axons. Central venous blood tunnel. Good. Not sinus. Sinus. Okay. Peripheral collection of axons. Exactly. Central collection of cell bodies.
Nuclear.
Exactly. Peripheral collection of cell bodies is ganglion. Central collection of cell bodies is nuclear. Remember I told you we used to call it basal ganglia, but actually it's the basal nucleus. Right? Are we good? I didn't screw up, right?
No.
Okay. No, I really like that. This class, you're very unique. You're a very unique class. You pay attention and you're very critical. And it's interesting. Most, and sometimes unforgiving. Okay. Which of the following mechanism is the primary process for the transmission of neuronal impulse across the synaptic cleft? Chemical. The electrical signal is converted into a chemical signal across the space and then converted again into electrical, not electronic. What's the difference between electrical and electronic? Electronic is charge studies. Electrical has to do with flow of current. When electrons flow one direction, current flows in the opposite direction, regardless what the charge is. Okay? Anyway, you can never be electrocuted by electronic devices. The electrical device can be electrocuted. All right, which of the following arteries is not? Middle cerebral. Good. Which of the following ion is not involved in the generation and propagation of neuronal impulse? Calcium is not involved, right? Okay? Calcium is not involved in neuronal impulse generation. All right, let's.
But forget the question. Did you say all of it?
No,
That was two.
Synaptic. That's why I specifically said neuronal impulse transmission. Impulse transmission at the neural level is basically driven by sodium and potassium fluxes. Okay, so let's kind of work this out. CSF production, ependymal cells. Remember that? Neuronal waste removal, microglial cells. Peripheral axon myelination, Schwann cells. Central axon myelination, blood-brain barrier. Exactly. You keep typing down my question. That is so not fair. All right, fine. Hey, you know what? Whatever it takes for you to remember the material, do it. At which of the following central locations do the second order neurons of the spinal thalamic tract end? The second order neuron of the spinal thalamic tract. Where did they end? First of all, where did they end first? At the thalamus, right? So we know that this order is out. Now the question is, which part is it thalamus on the same side or thalamus on the opposite side? Opposite side. And generally speaking, opposite is often called contralateral. Same side is called ipsilateral. Okay? Remember, they come and they exit, boom, and they go. Right? You got that? Why didn't somebody get that? The answer is wrong. Because the neurons come into the spinal cord and they cross. They cross right there. The second order neuron, oh, you're right. The second order neuron, they come up from the impulse, they cross, and then they ascend to the thalamus. You're right. It's on the opposite side. Right. The second order neuron. Okay? If I said first, it would have been on the same side, but it would be the spinal cord. Right. But it would then, by then, it would not be spinal thalamic. Let me make sure nobody is confused. Because the question is asking for second order neuron. That is, the second order neuron is the neuron that gets the information from the first order neuron. Remember the spinal thalamic tract, they are the ones that come into the spinal cord, cross at the same level, and ascend on the spinal on the opposite side. That neuron that crosses, that maybe handshake and crosses over, is the second order neuron. Is the one that takes it to the thalamus. And the thalamus, from the thalamus now it projects to the sensory cortex. That particular neuron ends on the opposite side of the thalamus because it crosses right from the beginning at the spinal cord. You got that? Yes. Excellent. Which of the following autonomic neurons are carried in the cranial nerves 2, 7, 9, and 10? Preganglionic parasympathetic. Good. Excellent. Excellent. Which of the following best describes the pattern of impulse conduction along myelinated neurons?
Saltatory conduction.
Saltatory conduction. Good. Now, tell me, we can use A and B as many times as we can. Motor neurons to the hamstrings.
You got shot.
I was trying to say things to everybody else.
Of course, it is not epinephrine. Everybody now knows this. Right? Remember, that is a motor neuron, right? Yeah. For the somatic motor neuron, both the solid acetylcholine, right? Preganglionic autonomic neurons, acetylcholine. Sympathetic neurons to the heart, norepinephrine. Parasympathetic neurons to the iris, acetylcholine. Sympathetic neurons to the sweat gland. Remember, all sympathetic neurons release norepinephrine except the ones to the sweat gland. That is why you give anticholinergic to people and they can have a heat stroke. Remember that, because they can't sweat. Remember that. I keep praying that you have mistakes. You can't afford to forget that. It matters a lot. Good. Which of the following autonomic neurons never employs acetylcholine as a neurotransmitter?
No. Well, are we using the exception?
Which of these never employs acetylcholine as a neurotransmitter? Have you ever seen where a postganglionic parasympathetic neuron uses acetylcholine? Yes, of course. Which of the following? King, give me an answer. You're confusing me, man. You say it's none of the above? All of the above? Which one never? Okay, does preganglionic autonomic neurons use acetylcholine?
Yes.
Good. Do postganglionic sympathetic neurons use acetylcholine?
Yes. No exceptions like one.
Okay. Do postganglionic parasympathetic neurons use acetylcholine?
Yes.
So it's none of the above. It's another way of trying to remind you that postganglionic neurons to the sweat gland use acetylcholine. Okay. All right. Which of the following body parts is represented? Okay. Which of the following subcortical structures is involved in the regulation of motor impulse traffic? Regulation of motor impulse traffic. Come on, people. Everything here is what we call the basal nuclei, right? The putamen, the globus pallidus, the caudate nucleus, together they make up the basal nuclei and they work together to regulate motor impulse traffic. Remember? And they are the ones that are also affected in Parkinson's disease. Okay? You're good?
Yeah.
So we're going to match the cranial nerves on the right with the appropriate origin on the left. Olfactory. Come on. Where does it come from?
Midbrain.
Remember I told you the brain stem, the bulb consists of midbrain, pons, and cerebellum, and now the cranial nerves fall from the midbrain, fall from the pons, fall from the medulla. I'm asking you now, where does olfactory come from?
Midbrain.
Oculomotor, trigeminal,
From the pons.
vestibulocochlear,
From the pons.
vagus,
Medulla.
spinal accessory,
Medulla.
Brain.
spinal.
Wait, you said 9 through 12 from the medulla.
Because spinal accessory has two components. There's a part that comes from medulla and a part that comes from the spinal cord and ascends and joins that particular part.
So we went wrong.
It's half and half.
You know, I've always told you something. Sometimes just be casual with the expressions. You see spinal cord here, and you see spinal accessory. I mean, and I didn't tell you you could use any one twice. You already used all four of them. And then there's the sixth one, and
Well, you used the double twice.
It's only 3 and 4.
So the answer would have
no, spinal accessory is spinal cord. Okay?
So can I clarify then? Because you said 4, 4, and 4. Midbrain, pons, and medulla. So should I take out?
I'm gonna give you an assignment.
No.
I want you to go and study the origin and formation of spinal accessory nerve.
Can I give it to you in August?
Okay, I'll wait till August.
Okay, thank you. Let me start clinicals and then I got your paper.
In which of the following central neurological structure is the reticular activating system located?
Oh, it travels along the whole thing.
All of the above. Good. Which of the following arteries is the most common site for circular berries aneurysm? Which one?
Vertebral.
Posterior, thank you. I think it's 20% anterior, 30% posterior. Look at the diagram I gave you. The posterior communicating artery is where you see the most, about 30% of the time. Okay? And you get more of that. At which of the following locations do the second order neuron of the spinal cerebellar tract end? Spinal cerebellar. They end in the cerebellum on the same side. They don't accusate. Okay? Okay, let's match. Cortical bowel. Where did they cross?
At the brain.
At the brainstem, right?
Yeah.
Spinal thalamic.
Thalamus. Spinal.
Where did they cross over?
Spinal segment.
Medulla.
The upper,
The lower medulla.
Spinal thalamic. Spinal thalamic tract.
oh, it never.
No, never.
Did you hear what Kristen said? What did he say? That's spinal, right? Yeah. They come and then they cross and they ascend on the opposite side. What's that we just talked about? Spinal thalamic tract. They come from the spinal cord. They go into the thalamus. They cross at the spinal level. So they cross at the spinal segment. Dorsal column. Dorsal column.
It doesn't.
No, it's not.
Cuneatus and gracilis. They are in the upper medulla, right? Right? So, and where do the spinal cerebellar tract and the cortical spinal? Lower medulla.
I thought you just said you just said dorsal.
Good. All right. Which of the following autonomic neurons are carried in the sacral spinal nerves?
Parasympathetic. Parasympathetic pose.
Post. Is it post or pre?
It's pose. Which is the pose?
They are on their way
They're
to
longer.
the longer one. So it's preganglionic parasympathetic neurons, right?
Yes.
So which of the following types of aneurysm is most likely cause of an intracerebral bleed in a 22-year-old female non-smoker with no significant past medical history?
A.
Thank you. Barry's aneurysm. Charcot-Bouchard microaneurysms are found in hypertensives. So if somebody with hypertension bleeds, it's because if you've had uncontrolled blood pressure for a long time, you develop this Charcot-Bouchard microaneurysm. It's a French word. So, and fusiform is just another congenital, but it's not as common. All right, good. All right, in which of the following central neurological structure is the, where did this? All right, so tell me now. A, B, C. A, sensory. B, motor. C, mixed. Olfactory.
Sensory.
Oculomotor.
B. Wait,
No, it's
Oculomotor is just
Oculomotor is motor. Trigeminal.
mix. C. Mix.
Vestibulocochlear.
Well,
Sensory. Vagus.
mix.
Vegas is mixed.
Eh?
Oculomotor is sensory.
Oculomotor is sensory.
No, that's optic. Optic receives the senses. Motor the muscles.
Vagus.
Mix.
Hypoglossal. Thank you. It's motor. Your neurons cross-fired. So we're going to match these subcortical structures on the right with appropriate function on the left. PT3. Hormone regulation. Thalamus.
No.
General
General sensation. Thalamus. Amygdala.
anger,
Hippocampus.
memories,
Hypothalamus.
autonomic modulation.
Thank you. All right. Now, this, I dare you to do this one and get it done. So, these are herniation syndrome. All right. These are the clinical manifestations. Uncle. Thank you. Who said that? Good. Okay. Pupillar inequality. Central.
Loss of consciousness.
Central compresses the brain stem, the midbrain.
Okay, never mind.
So what are you going to have? Sunset gaze. Sunset gaze. Tonsillar. Tonsillar.
Pupillar, urinary continence.
Okay. You already said uncle is pupillary. You said central is sunset gaze. Tonsillar is what?
Doesn't it
Okay.
go down into the brain?
Into the from the magnum. Yes, lots of questions. It compresses the brain stem. Cingulate. You remember what cingulate is? The cingulate gyrus.
Urinary incontinence.
Urinary incontinence because it compresses the frontal lobe, where your decision, you should know where to pee and when not to pee. It's your frontal lobe decision, right? So cingulate. Transcalvaria.
Skull fracture.
Skull fracture. Okay. Excellent. Thank you. So I think I'm ready to go to my next class now. You all good with this, right? Yeah. Okay. Oh, my back hurts. All right. So let us do. Do you guys want a 5 minutes break?
Yeah.
All right. Don't do it.
Can you put the slide too? Or do you post it?
I did.
Okay.
I did.
Okay.
Tia, please tell them. I posted the slides.
Yeah.
Okay, thank you.
No way. No. What did you have today over there? I'm up here, you go here.
Wait, I need, you want me to try
Send me
approval from you. So we have this Saturday, we're going to Granada on Broadway. Some of our have a second event next week. So they do it every third Saturday.
Who does it?
Dr. Davis.
Okay.
Every third Saturday.
You get the
I already asked her, yeah.
And she said it's okay?
Yeah, so there's no test around that time.
Okay. Yeah, very good.
Just because today is not in the office.
But tell, let Greta know.
We went over the most common type for the sacral aneurysm. We said it was possible for
Actually, no, you have to go by what is there. Because the truth is, it depends on which series of studies you do. Posterior and anterior communicate with the compete. Right? But in my, I need to correct that. Yes.
I don't think that was an answer.
I think he said posterior.
Yes. That's what I was saying now. That when the class comes, it depends on. It depends. There's so many studies on it. You look at some, they say it's posterior, some say it's anterior. But for my exam, it will have to be anterior because that's what it's When are we supposed to finish?
1:30?
No,
2.
1:30. Why? 1:30. And you get a 30-minute break, and then 2 minutes starts it.
We're supposed to finish at 1:30?
Yeah, and then EKG starts at 2. 2 to 4.
I will probably do EKG for 90 minutes. So we can finish, at least go some. I'm so sick of EKG, man. New York is warmer than LA. So weird. All right. So we're going to talk about. Thanks everybody. 5 minutes break.
Eventually.
Yeah, I like that.
Mine's not, yeah, Echo. Mine's not too bad. Okay. 100 to 5.
I'm missing half of the class. How can I stop? then I'll have to repeat myself. I'll start doing remediation. All right, so now you talked about neurophysiology. We're going to now talk about neuroevaluation. So neurological evaluation is really how do you assess patients for neurological function in the clinic. So neurological evaluation is a functional assessment of the nervous system. And since we talked about the nervous system as consisting of the cerebrum, the brainstem, right, spinal cord, the cerebellum, we test each and every one of these components. The way we test the cerebral cortex is we do what is called a mental status examination. Okay? So whenever you do a mental status examination, you're actually looking at the cerebral cortex. Whenever you assess somebody's level of consciousness, you're actually saying, you're testing, you're evaluating, making a statement on the reticular activating system. And whenever you test somebody's cranial nerves, you see level of consciousness and cranial nerves together test the brainstem. That is why it's extremely important for you to remember that the cranial nerves, they exit the brainstem from the midbrain to the medulla. So when you test somebody, when you make a presentation and you say cranial nerves are grossly intact, basically what you've said is the brainstem is fine. Okay? If you say somebody is awake and aware, basically what you said is the brains are fine. Now, and spinal cord, you look at the sensory motor functions, right? And then for the cerebellum, you look at gait and balance. You know what the difference is between gait and balance? Excellent.
The way you walk.
The way you walk and the way you stand. Good. Good. So, generally, in the clinic, we do mental status, cranial nerve, motor function, sensory function, balance and walking, and we look at reflexes and coordination. You did all that in physical diagnosis, right? You must remember how to do those things. Very important. You can't forget. So, how do we assess mental state assessment? Right now, I would say you're all alert and oriented, right? That's the way most people say it. But the way I want you to say it, say patient is awake and aware. Because you know, orientation is really awareness. And usually in clinic, we test awareness to time, place, person, and situation. So does the patient know what date it is, what time of the day it is, what day of the week it is, what month it is, what season it is, what year it is? All of that is where you assess time. Place, do you know what continent you're on? Know what country you're in? What state, what county, what city, what building, what floor? These are your test orientation to place. Person, do you know who you are? What is your name? And pay attention to this note here. Orientation to person is the last element of orientation to the lost. The last thing you lose when you're losing your mind is who you are. Okay? And then situations. Do you know what's going on? Are you aware that you're in the hospital, you're sick, and you need help? Okay? Or do you think you're in a motel room waiting for your girlfriend? So, alertness, awake and aware. So you say patient is awake and aware. And oriented. Oriented is what most people say. It doesn't sound right. It does not convey the idea. You know I have issues with it? Because you say patient is oriented, but you're testing time, place. Are you saying they're oriented to time? Does that make sense? You say you are awake, they are awake and aware. So what do you mean? Oh, it's aware of the time, the place, the situation. You see, that makes grammatical better sense. But you say oriented to time, place, and person. What is that? Are you oriented to time, place, and person? You know what I mean? I mean, grammatically, it just doesn't sound right. So I want you to try to say it differently. Once you say awake and awake, people will look at you. They will take a second look at you. Then the presumption they will make is that you don't know what they're talking because you're a BA student. Then you say, no, aware of time, place. Aware of time, place, person, and situation. Sounds way better than oriented to time, place, and person. Right? Now, I'm moving forward. We're done with mental state. Now, consciousness. How do you describe consciousness? This is how many people don't even know how to describe consciousness. This is how I want you to describe consciousness. Your patient is awake. You're awake. That is normal. When your patient is not awake, you must describe them precisely in one of these terms: somnolent, lethargic, stupor, or in coma. I don't want you to ever find yourself in a situation where, like I witnessed in the emergency room one day, a woman went to the doctor, emergency room doctor, and said, "Is my child in coma?" You know what the emergency room doctor told this woman? She said, "I don't know if the child is in coma right now, but she's unconscious." I couldn't help it. The emergency room doctor couldn't tell this poor woman, if my child is in coma. What is the big deal about coma? So let's go through it. So you don't ever have to say that to anybody. So somnolence. What is somnolence? Sleepiness. Patient is sleepy, but can be awakened to begin and finish a dialogue. So you went to the patient, Mr. Jones. Yeah. Oh my God. How are you? I'm fine. Is your pain gone? A little better. All right, see you tomorrow. All right, see you, Doc. And he falls back asleep. So he's somnolent. He's sleepy. Lethargy. Your patient can be awakened to begin a dialogue, but cannot stay awake to finish the dialogue. So you wake, Mr. Jones, how are you doing today? I'm fine. How is your pain? Mr. Jones, he falls asleep right in the middle of the conversation. That is the lethargic patient. A stuporous patient is the one that you say, Mr. Jones, you say, how are you? You can never get him to wake up to begin the conversation. Right? Coma is when your patient is unresponsive. You call him, you shake him, he only responds to pain. Right? Your patient is comatose. So these are distinct clinical states. You can't be confused about them. Because you know what? A patient that is somnolent today but lethargic yesterday is getting better. And what interns do that is so horrible is they just say, oh, it was altered. Remains altered. How would you ever monitor progress? How would you identify when the patient is improving? If you keep writing altered, what kind of alter? What is the alteration? Is it going from coma to stupor, or is it going from lethargy to coma? What is it? Just telling me patient is altered, you're not telling me anything about the patient. Right? My grandmother knows the patient is altered. What more can you tell me as a clinician? Yes, Mr.
I just have a question. Going back to your example, you're talking about the mom that asked the doctor, the baby's in coma. The reason I would see the doctor not like answering with he's in a coma is just because like the understanding that if you're in a coma, pretty much you're in bad condition, right? That's what I'm thinking. Like
it is.
So then how would you say it? How would
he's in a coma.
You would say he's in a coma.
Yeah. You know the truth is in critical situation, you want to carry family with you. Paint the right picture. Because if you paint, make it like easier to bear. When what they don't expect happens, they will start taking a second look at you. They will be seeking second opinion. But if you let them know what is going on from the get-go, this kid is in coma, we're going to try everything we can, but he's stable. He's in coma and he's unstable. I don't know what will happen. You know that lady died, right? Our staff that developed an aneurysm. She died on Monday. Jan. The one in the presence of this.
Where was that aneurysm?
It was one of those. Oh, by the way, the commonest site for Barrett's aneurysm depends on which series you look at. If you look at neurological series or neurology series, different, but it's always between anterior and posterior communicating. So, technically speaking, it's the communicating arteries that is commonest site. But for my exams, because what I gave you, the diagram is really anterior, so anterior communicating is the answer, not posterior communicating. Okay, for my exams. But if you look in the literature, you'll see this competing between anterior and posterior. When we're going through the question, I have said posterior, but it's anterior. Okay? Alright, so you know how to access level of consciousness. Now, the surgeons, this is one place the surgeons, I was even surprised when they came up with Glasgow coma scale, because surgeons did this. Because they couldn't go with internists putting altered, because we were not as specific as we could be in terms of somnolent, lethargic, stupor, coma. So they came up with this. And they have their EVM, they look at eye opening, verbal response, motor response, and they give their patient scores. And based on that, they're able to find out what the severity of the brain injury is. I'm never going to ask you anything about this, just for you to know that there's Glasgow coma scale that surgeons use, right? And neurosurgical units also use it as well. But as an internist, I don't use Glasgow coma scale. I want to know, is my patient somnolent, lethargic, stuporous, or in coma? And every day, I'll say, still in coma, or now in lethargy, or just somnolent, or based awake. Okay? I don't use Glasgow coma scale. And if you find yourself on the internal medicine service, don't use Glasgow coma scale. Don't use Glasgow coma scale. If you're on surgical service, don't go telling them patient is stuporous. Tell them the Glasgow coma scale. Okay, so that's just, you just need to know that. And we carry this in the pocket all the time, so you don't need to memorize it. If you use it often enough, you remember it. Now, whenever you say somebody is in coma, you must say whether they're still alive or they're dead. Because if somebody is not responding to anything but pain, they could be dead. If they're responding to pain, they're probably not dead. But if they are not responding to pain, you need to now decide, is the patient brain dead or not? The way we do that is we assess the brain stem vitality. You know we do cranial nerve, right? If somebody that is awake, you put the perfume in their nose, you tell them follow my finger, you look in their hood wheels, they can follow command, right? When somebody is in coma, you can't do all that. You have to depend on some very primitive reflexes. So you do the pupillary-like reflex and the oculocephalic reflex. This oculocephalic and pupillary employ the optic nerve and the oculomotor nerve, right? So this is testing the midbrain, right, in a comatose patient. What is pupillary-like reflex? Shine light on the person strip. What is oculocephalic? If somebody is in coma and you turn their head right, their eyes look left. If you turn their head left, their eyes look right. That is normal. When you don't have that, something is wrong. Your brain cell is not working. Okay? In the pons, we do vestibulocochlear. Vestibulocochlear is based on the eighth nerve, or you do corneal reflex. Corneal reflex is you get a cotton bud, put it into your wig, and from the side, not from the front, from the side. In a comatose patient, it does not matter. But in a somebody that is awake, it matters because they will close because they will perceive visual threat. Somebody blinks for visual threat. That is not corneal reflex. That's visual threat. Corneal reflex, the sensory arm of corneal reflex is carried in the trigeminal nerve. The motor arm is carried in the facial nerve, the seventh nerve. So that is really what you're testing. Okay? So, but if somebody is in coma, you do vestibulocochlear and you do corneal reflex. I will tell you more about vestibulocochlear a little bit later. Now,
have you checked the cornea? They're in a coma, aren't their eyes by default closed?
Yeah, some people have coma visual where they coma and their eyes are open.
Oh.
Yeah. You haven't seen people that are dead and their eyes are open? No. Yeah. I mean, generally speaking, we tend to close the eyes. You run your hand down to close it. But some people die with their eyes open, especially when they die horrible death. When people die in fear, they die with their eyes open. You know, like in terror. But when people die in their sleep, they die with their eyes closed. Right? I saw a woman dying one time and she was looking for her daughter, and she died with her eyes open because she wanted to see the daughter before she was. So she kept asking, is she here yet? Is she here? She was still looking for the girl. I actually cried when I closed the eyes because she died not seeing the only child. You know, and I felt so bad. That is not a good way to die. You know, you should die in peace, not worrying and scared. You know. Anyway, vestibulocochlear we'll talk about, because you know there is no reason to do vestibulocochlear and oculocephalic. We do vestibulocochlear when we cannot do oculocephalic. You see, I told you about oculocephalic. You take the head and you turn it this way, and you watch where the eyes go. I turn it this way, you watch where the eyes go. If somebody has cervical spine fracture, you can't do that. Right? You have to now use vestibulocochlear. In vestibulocochlear, we put water in the ear and we look at the motion of the eyes. I will explain to you later on. What do we do with the medulla? We test gag. Gag, how do you test gag? You just pull the engine tube back and forth, irritate the pharynx, and you stimulate the gag reflex. Then the cough reflex, manipulate the suction tube in the tracheal tree. You bring up cough. So if somebody is in coma, but they're able to cough, and when you manipulate the engine tube, they gag, and you put water in their ears and their eyes move, there's hope. You say, well, he's in coma, but it's not very deep coma. It looks like his brainstem are still okay. The inflammation is making the brain swell. As the brain shrinks, pressure will reduce in the brain. It will come around. But let's say you now come the next day, and now no more gag, no more cough, no more pupillary light reflex. You tell the family it's just gone worse. Now he doesn't have any brain stem function. Right? So when somebody is in coma, you want to assess if they have brain death, because the absence of brain stem function is what means the patient is likely brain dead. You now have to do official brain death evaluation. Okay, so you know this. Pupils with bright light they constrict, dim light they dilate. That is how it is. The sensory arm is in the optic nerve. The motor arm is in the oculomotor, right? So that means midbrain is fine, right? This is the vestibulo-ocular or the oculocephalic, also known as doll's eyes, right? You know, the head this way, the eyes move that way. That controversially is called controversive visual fixation, right? So this is what normal is. If you turn the head and the eyes follow the head, that's not a good thing. Okay? So, if you turn the head this way and the eyes go that way, that means you are not looking, the patient is not exhibiting the controversive visual fixation. That is the problem. Mark my word. What you're looking for is controversive visual fixation. That is what normal is. When you don't have controversive visual fixation, you say you have absent doll's eyes. That means the brain, the midbrain is not, we have lost the midbrain. Alright? Now, vestibulocochlear reflex. So you see what happens is, you take cold water and you put it through the middle into the ear. When you put cold water through the ear, what happens? You set up a convection current, right? You know how that works. The same way the water freezes and ice floats. Whenever you put warm, you heat up water, it expands, becomes less dense, it rises, right? When you freeze water, condenses, and the ice floats, right? That's the normal thing. All of that is dependent on convection current. So when you put cold water in somebody's ears, you set up a convection current in their inner ear, and the brain will get the impression that this person is moving. And because the brain gets the impression that somebody is moving because of the convection current in the inner ear, the eyes will move accordingly. In a normal person, when you do it with cold water, the eyes will move towards the ear of irrigation. When you do it with warm water, it goes. Okay. When you do it with cold water, it goes towards the opposite side. With the warm water, it comes towards the side that you're irrigating. That is what normal is. Okay?
So the normal is not the picture? So the picture is
abnormal oculocephalic reflex in a comatose patient. This is the abnormal. So you put cold, it comes to the same side. So that's why I put this, because the first time I put this slide, everybody was getting so confused. Cows is the normal, cold, opposite, warm, same. Right? That response is reversed in coma. Okay? It is reversed in coma, and it is completely lost in brain death. So if the patient does not respond, that brain is dead. Okay? Don't get confused, okay? This is the abnormal response. The normal response is cows. Okay? You got that? Now this is corneal reflex. If it is absent, because the patient's brain is dead. Okay? And remember, I told you, you come from the side, not, of course, if somebody in coma does not matter, right? They cannot respond to any threat. Okay, then gag and cough reflexes are bulbar reflexes. Again, they are absent in brain death. Okay, so you understand what I'm saying. Whenever you say somebody is in coma, you must evaluate the brain stem. Absence of brain stem function in a comatose patient equals brain death. And there are two ways you're declared dead. Either you are brain dead or you're heart dead. Right? Whenever you now say somebody is brain dead, that is a critical decision. Just wait. Because somebody brain dead means they are dead. You now need to do the formal test to confirm that the patient is brain dead, because that means you're going to shut off the life support. Okay? So how then do you do that? You're going to pre-oxygenate them with 100% FiO2, because you want to make sure you give them every single chance of survival. If you turn off the life support on somebody who is struggling, you just murdered somebody. Okay, so that is why it's so controversial. There are ethical committees that will not even let you think about this. But again, you look at cost and viability. What kind of life is this? Right? Then debate back and forth. Okay. It's a very difficult thing to do, but you must know how to do it, because you'll be involved in it. Just know when it is due. You don't do it in everybody that's in coma. The only time you look for brain death is when somebody is in coma and they have no brain stem function. You owe it to the family to do a brain death evaluation. So you pre-oxygenate with 100% FiO2 for about 10 minutes. You make sure the patient is stable. Blood pressure is normal. They are not tachycardic. Their temperature is fine. You make sure their PCO2 is 40. Because remember, if PCO2 is too low, the patient will stop breathing to accumulate CO2, right? Okay? So, then, only when you've done all this, you now disconnect the patient from the mechanical ventilator, right? And you give them the oxygen line. You can put it through the tube, and you monitor their blood pressure pulse and pulse ox. You observe chest and abdomen for movement. What are you looking for? Attempt to breathe by the patient. Then you obtain blood gas every 3 to 5 minutes. So you have to do this with an outline. An arterial line has to be in place, right? If you wait 3 to 5 minutes and PCO2 rises above 60, and your patient did not make any effort to breathe, the patient is dead. You stop the test. You reconnect the patient to the ventilator. You call the family and say, the person is dead. You're only keeping them alive with the machine. Okay? So this is very important. This is the protocol. It's very complicated. This is basic gist of it. I'll tell you what happened to me when I was an intern. When I was an intern, I was told that the ethical committee, they met and they decided that the patient is brain dead, right? I wasn't there when they did the brain death evaluation, but they told me to drop a neurology consult, and I did. And the neurologist came in the night when I was away. I was not on call. He came in the night and did the test, and he said the patient was brain dead. Okay, so he said disconnect the patient from the vent. You know what I did? I came the next morning and I went to the wall and I turned the switch off from the wall. Is that how you think I should have done it? Would you have done that? Is that what you would have done? Disconnect the patient. I turned off the switch from the wall. That's what I did. Because disconnecting, I did not realize that disconnecting is going to the ET tube and disconnecting the tube so that the patient's airway is now connected to the atmosphere. So if they breathe, they can get atmosphere. When I turn off the switch, it's like I'm suffocating the patient now. If the patient was not dead, I'm now forcing the patient to breathe through the entire circuit to generate enough pressure to get the oxygen from the wall through the machine into their lungs. I was just like 6 weeks into internship. So when I turned that thing off, this patient started making this weird movement. I'm like, no, if you're brain dead, you don't move. Then I flipped the switch back on. I was so mad. Went to the consultant. Like, what the heck are you doing? When I disconnected this patient from the vent, he started moving. And the family was there. They're like, no, he's brain dead. Man. He's moving, my friend. He can't be brain dead. So I told them I wasn't going. I mean, I refused for them to turn the vent off. The guy died 2 weeks later. But I was on the service for 1 month. And I was just the second day or so on that service. I'm like, you're not going to. If you take this vent off, I will take a witness stand against this team with the family. Because we all saw it. And I couldn't. You know, I was just making up stories. Because the daughter was like, why is he moving? I'm like, you know. You know, it's the pang of death. After a while, my conscience couldn't take it anymore. I just keep the switch back and say, we'll do this some other time. You know? But I knew the daughter was looking at me like.
I don't think you know what you're talking about.
You know, so this is, I mean, it's a serious business. Taking people off life support is one of the most difficult decisions to make in medicine. So let's talk about disorientation. Like, for instance, you know, I told you that you should stay away from using the word oriented. But when somebody is not aware of the time, the place, situation, then they are disoriented. Right? That is, they are confused. This disorientation just makes you confused. Right? Now, when somebody is confused, you have to, there are three things, basically three things I think you should think about, but in the books they always talk about depression. I don't think depressed people are disoriented. No. Depression is depression. When you're depressed, you're depressed. In my 26 years of practice, I've not seen a depressed person that is disoriented like that. Let me tell you how disorientation looks like in depression. Somebody just lost their husband and their child. Like my wife's friend. The son met this girl, right? And they were going to go to Nigeria to go get married. And everybody was going, but for some reason she wasn't going to. And she told them that she was going to keep the last born. And everybody went to Nigeria to do this wedding. On their way to, they got to Nigeria, on their way to the village to go do the traditional thing, everybody crashed and they all died. This poor woman was not left with her husband. Of course, she didn't know what to do because she's been in the house, she has not money, lots of things. They have her son, her husband, and two other children. The other family was like this wife came with the curse, not destroyed the whole family, everybody was dead. So she was home. After like 3 months, people were worried about her. She went to see her. She didn't know what happened. That is how disorientation looks like in depression. So I don't really think that depression should be considered a differential diagnosis of disorientation. When depression causes disorientation, it's an overwhelming depression. You know it, right? So for me, technically speaking, if I want to tell you what are the differential diagnosis of disorientation, is delirium, Alzheimer's, and psychiatric disorder. Okay? And how do you tell them apart? This table says you should look at onset, the cause, the duration, consciousness, attention, orientation, look at the speech, thought. This is a very nice attempt to try to help you differentiate delirium from Alzheimer's and psychotic disorder. I have an easier way for you. Just remember baptism. Okay. Look at this person's behavior. When somebody is acting crazy, you know it. Okay? So, if they're acting crazy, you know it's probably not Alzheimer's. It could be delirium or psychotic disorder. How do they appear? Crazy people appear weird. They're weird. They will tie, they might wear 2 pants, might wear 2 shirts, they might wear 4 shirts. You know, appear crazy. You know what I mean? You know what crazy is? Delirium, they have more behavioral problems, but they're like crazy people, but only short term. This guy was normal last week. He left home for college, and they brought him like this. That's delirium. Perception. Perception is this person having hallucination? Okay? Hallucination. Are they seeing things? Are they hearing things? If somebody has perceptual disorders, they are likely delirious or psychotic. Okay? They are not Alzheimer's. Notice what I'm doing here. I'm not telling you how to tell delirium apart from psychiatric illness. No. I'm telling you how to differentiate deliriums and psychiatric illness from Alzheimer's. Okay? Alzheimer's patients don't have perception problem. Now, thought disorders, thoughts, delusion. Is there any false belief that this person is harboring? Like, I am God. Don't you know who you're talking to? I can delete you right now and you will vanish. You see, that is a formal thought disorder. That is a very common problem in psychiatric illness. Okay? Insight. Crazy people don't know they're crazy. They think you have an issue. Alright? Speech. How is this person talking? Is the person talking coherently like a normal person, or are they just talking any kind of way, which will put you more towards delirium? But you can also see it in psychiatric disorders. And their mood. Are they like super elated, or are they depressed? So what have I told you? If somebody has no behavioral problem, normal appearance, no perceptual problem, no thought disorder, they have good insight, they have normal speech, they look at you like they have normal mood and affect, then that means they are not crazy. You cannot say they have psychiatric illness. Why is this important? Why do I not want to? Because this table here is good. Everything there is true. But it's too complicated. You know? And you must be able to tell in the clinic if somebody is crazy or if somebody is sick. I'll give you an example. A man brought his mother to me. The sister has been maltreating the mother in Nigeria and taking the mother to psychiatric hospital, and they put the woman on crazy people's medication in Nigeria. That is Lagactil and all these crazy medicines. So the son asked for the mom to be shipped to him. So mother came, and he called me and said, my mom, something is wrong with her. She talks to herself. I'm like, really? She talks to herself? Okay, bring her. And I brought the woman. The mother was intelligent, talking normally, and she misses her husband. Husband has been dead. And every time she talks to herself, she talks like she's talking to her husband, like her husband is alive, right? And they think that means the woman is crazy. So they took her to some doctor who think the woman is actually crazy and started giving this woman medications. You know, in many of these developing countries, the way you treat madness is to sedate the patient 24/7. So the woman couldn't function. So I just saw the woman, and I just basically ran through baptism. She was not misbehaving. She was not cursing anybody out. She was not destroying anything. She appeared okay. She took her bath, brushed her teeth, makeup. She was not seeing things, right? Although when she's at home, she's talking, but she's not seeing things. You know, she's never told the son that, oh, did you just see your father? No. She's talking like he's there, but he has never told anybody that my husband is in the room. That distinction is important, because perceptual disturbance is hallucination. Are you seeing things that are not there? She didn't have any thought disorder, no false beliefs. She knew she was in America. She knew she had come to Nigeria. She knew she didn't like what her daughter did to her. Right? She was aware of all these things. She had insight. She didn't think anything was wrong with her. She didn't they're overreacting. Right? She misses her husband. That's all she could tell me. And she had no speech or mood disorder. So I told the son, stop all those psychiatric medication. And I did the test I will go talk about a little bit later. And the woman continues to talk occasionally in the house. I'm like, leave her alone. What is wrong with her talking? They say, wake up in the night to go pee and she'll be in the room talking. You know, okay, so what's the problem with that? She's talking. Is she destroying things? Is she breaking things? Is she following anybody outside of the house? Is she trying to leave the house? Why are you bothering her? She's 78 years old. Her husband died 8 years ago, and she's been alone since then. So you see, in practice, people will come to you with that kind of crazy stuff. Sometimes it will be children bringing their parents to declare them, for you to declare them incompetent so they can be in control of their social security checks. And you as a clinician, you have to make the best decision in the best interest of that patient. So it's extremely important that you know how to tell delirium from Alzheimer's and psychiatric disorders, because it has a lot of implications for you in practice. Just know that baptism does not help you tell delirium from psychotic disorder. No, it helps you tell who is demented. Okay? Demented patients, they behave okay. There are some dementia with exceptions, but generally speaking, They don't have behavioral problem. Appearance is good. They have no perceptual disturbances, no thought disorders. They have insight, or they may not have insight, depending. But overall, when you put all of the baptism element together, you'll be able to make a good decision. Pay particular attention to insight, because psychiatric patients do not have insight. Okay? So when we have this kind of situation, we do what is called mini-mental status examination. So mini-mental status examination is a very good test by a guy, actually from UCLA, Fallstein test. It was published in 1975. It's a 30-point assessment. It assesses language, memory, and computation. And it's a measure of cognitive impairment. Normal score is 24 to 30. This is how you rate it. You must know this like the back of your hand. 93 to 20, 19 to 23 is mild, 10 to 18 is moderate, 0 to 9 is severe. How is it done? Look, orientation. You ask the patient, what year is it, what season is it, what month is it, what date is it, what time it is. And then you put the number of 1, 2, 3, 4, 5. How many they got right, you put there, right? They ask them, okay, examine, you show them 3 objects, usually unrelated, right? And ask them to, what is this? You show them one by one, right? And then you keep it away, come back later and ask, what were those 3 objects I told you to hold on to in your mind? How many they remember? You put it there. Right? And then attention and calculation, depending on their level of education, you can do serial 7 or serial 3. You can begin from 100 or from 50, depending on the level of education, right? So 100 minus 3, 197 minus 3, 94 minus 3, 91 minus 3, you do that. Okay? So, and then recall. Then you now ask them for the name of the 3 objects you giving them up here. So remember, in registration, you show them an object. You tell them to name that object. If they name all 3 of them correctly, that is fine. Now tell them, hold on to it. And then you now ask them to recall those 3 objects here. And then you put the numbers there. And then language, you show them any 2 objects, ask them to name it. Then you tell them to repeat no ifs and or buts. And then you write a 3-stage command on a piece of paper. Like, you say something like, touch the table, or pick the pen from the table and put it in your pocket. Right? So you say 3-stage command. Something they have to read and then do it. Like, ask the patient to read and obey a written command, ask the patient to write a sentence, and then score 1 each sensible, one area. And then you now show them this visual thing and ask them to copy it on their own. So these are the components of the mini-mental status exam. These days, medical assistants are doing it, but sometimes they will expect you to do this. You do this whenever you're thinking that somebody's mental status is not quite there. They are disoriented. Okay? And you're thinking dementia. Now, let's...
Is it 3 columns because you need to do it 3 times?
No, you don't do it 3 times. You do it over time.
Oh.
Okay, so you have a baseline, first visit, second visit, and all that. Right? That's why you put the dates.
Okay.
You got it? You put the date, the date will be the first one, the second one, the third one, right? Right. Okay. Now, we've seen the mini-mental status system, right? I went over it on purpose. Let us see, how does that really test the brain function? How does that work? So let's start from the beginning. In order for you to repeat a word after hearing it, you have to get information from your Wernicke's area, right? All the information from your ears have to end up in your Wernicke's area, right? You have to understand what was said, what was told to you, right? You have to now transmit that understanding to the Broca's area, right? And the Broca's area has to understand what you heard. and then generate the necessary neuronal connection to enable you to repeat what you just said. This is the neurological process behind you telling somebody to repeat no ifs and or buts. In order for somebody to copy a design, they have to foresee it. They have to be able to get information of what they've seen into the motor area and then move appropriate nerves for different muscles to copy exactly what they've seen. So now that I've told you that, let's read what I wrote here. Wernicke's area transforms sensory input from the primary auditory and visual cortices into words and design representation with neural meanings. That's the key word there. Now the Broca's area takes and transforms the word representation into a sequence of motor articulations that lead to the repetition of the word. Similar processes involved in parietal lobe and transform the design representation into a sequence of motor activities that lead to copying the design. So everything I just said in so many words is what I put there. Now, you see that there really needs to be some serious connection between the Wernicke's and the Broca's area, the occipital cortex, some important connection for information to go back and forth, for you to do the simple test that you're looking at.
Dr. Martin, I'm sorry to stop you, but our classrooms are 1:30 and then we have EPG at 2.
Yeah.
It's 1:34.
I know. So I decided to go on to 2, give you 30 minutes break, and then we'll be waiting for 9 minutes. Okay. So, all right. So, in order for those information to go from the Wernicke's area, the Broca's area, and be able to do the simple things that you see on that mini-mental status exam, you have this thing called the perisylvian language network. You know where the Sylvian fissure is, right? The Sylvian fissure is the space between the temporal lobe and the parietal lobe when you look at the brain from the side. Right? You all did, you remember Sylvian fissure?
Yeah.
Okay. Perisylvian means a network of areas around the Sylvian fissures. That PLN, the perisylvian language network, is so important. Wernicke's and Broca's areas are connected by the arcuate fasciculus, and along with the temporal, the prefrontal, parietal region around the Sylvian fissure, they make up the perisylvian language network. This language network on the left side dominates 90% of right-handed people and about 60% of left-handed people. So your ability to speak, understand language, and use language is determined most of the time by the left perisylvian network. Even if you are left-handed, 60% of the time, the left PLM is still responsible for that function. That is so important. You have to remember that. Arcuate fasciculus and all of the areas around the Sylvian fissure, this is the Sylvian fissure right here, together they make up the PLM that is responsible for language use. Alright? Now, when somebody is not able to use language, either understand it or produce it, we call that aphasia. So the patient is aphasic. The commonest manifestation of aphasia is anomia, inability to name. Okay? There is a reason in many mental states you tell people to name objects. Okay? You're testing for anomia. Now, this is where I want you to pay attention. Anomia is the most common finding in a aphasic patient. Not being able to name something and not being able to recognize it are two different things. Not being able to recognize it is called agnosia. If I show you this and say, what is this? You could either call it paperclip, or you could be like, it is used in, see, or I don't know what else. If you have anomia, you're not going to be able to name it. You'll be trying to describe it. Right? That's how anomia presents. Agnosia is, you don't even know what the heck it is. But you cannot call it agnosia if the patient is not expected to have seen it before. If you take this to a farmer in Burundi and say, what is this? He'll take it, he will look at it. I don't know what it is. He has not seen it before. Right? He's not expected to know it. Right? But if I show it to you, show this to a student in America and doesn't know, you've got a problem. You know? So I just want you to know that anomia and agnosia, they are similar, but they are very different. Now, in somebody with aphasia, anomia will be associated with impaired comprehension of spoken and written words. So you will have, if somebody has Wernicke's aphasia, they have anomia plus impaired or inability to understand written or spoken words. That is why you tell the person to read and obey a simple command. So when you do mini-mental status and you show them a command that is written, close your eyes and open your mouth, and they cannot do that, that means they can't read it, they can't understand it. That is, they are not able to read it or understand it. That is an indication of Wernicke's aphasia. So they will have anomia plus inability to understand spoken language and written language. In Wernicke's aphasia, the patient is speaking. So speech is fluent, but the problem is the patient uses wrong words and incomplete sentences and tend to describe rather than name the object. In Wernicke's. In Broca's aphasia, where the problem is in the Broca's area, they have anomia, but in addition to anomia, they have inability to produce speech. So speech is non-fluent, difficult to articulate, also known as dysarthria. That is why the patients cannot pronounce no ifs and or buts. So when you have problem with speech production, you have Broca's aphasia. When you have problems with language comprehension, you have Wernicke's. Okay? And when you have damage to both the Wernicke's and Broca's area, you have both Wernicke's and Broca's aphasia along with anomia. You got that? Excellent. Remember, in the mini-mental status, you also tell the patient to obey three-stage command, right? Inability to obey stage command or complex motor command is what is known as apraxia. Inability to obey complex motor command is called apraxia. There are two types of apraxia. Okay? There is ideomotor apraxia and there is construction apraxia. Ideomotor apraxia is inability to accurately mind the use of a tool or imitate a complex hand gestures, in spite of intact language, sensory, and motor function. So, whenever you have ideomotor apraxia, you cannot use tool. You cannot even copy hand gestures, even though you don't have paralysis. Ideomotor apraxia indicates damage to the premotor area in the frontal region of the PLM. When you tell the person in mini-mental status to obey a three-stage command, you're looking for ideomotor apraxia. Okay? Notice that it is when you have damage to the motor cortex. Premotor cortex. Remember that I told you that the frontal lobe is where the command to the nerves as to which muscle is to contract, which muscle is to relax, is composed at the same time in this premotor area and then delivered to the motor area to execute. Okay? So that is why damage to your premotor cortex will present with ideomotor apraxia. Now, construction apraxia, which is the second type of apraxia, is basically inability to accurately copy or come up with complex line diagrams of objects. That is what you try to elicit when you tell the patient to draw the face of a clock. Okay? If somebody cannot do that, their parietal region is damaged. Because remember, your sensory cortex is where? In your parietal region. You have to be able to see that diagram, understand it, for you to copy it. Okay? So construction apraxia. Now, let me make it more clinically relevant. These are definitions. Let me show you how this stuff appears in clinic. In practice, how would you see it? If you do neurology elective, and I recommend it, because your curriculum, you have neurology, but you want to see your rotation doesn't have neurology, your core rotation doesn't have neurology. Try to do a neurology elective. You will see amazing things in neurology clinics. Right, good. See how ideomotor apraxia presents. Difficulty sequencing a series of steps. So a patient is trying to wear their socks and they're putting the socks on top of their shoes. The sequence is messed up, right? Somebody is trying to wash, right? They go to the kitchen, all right. They are in the kitchen, they have the hand under the sink, but they're washing and the water is not on. They have omitted a step. They forgot that they have to turn on the tap before they can wash their hands. And then attempting to drink juice without opening the container. People with neurology damage, they have these issues. They carry a bottle and they will, it's not coming out, Jimmy. Dad, it's not moving. Lack of knowledge of how to use familiar tools and objects, like for instance smearing toothpaste on their faces. These are all ideomotor apraxia. So patients will come, children, daughters and sons will come to you and describe what this parent is doing. You need to be able to put it in a clinical context so you can connect it to a part of the brain and then determine how you're going to investigate it. Right? Eat bar of soap because they think it's candy. Uses toothbrush to comb hair. Tries to maneuver wheelchair by pulling the armrest or even bringing knife to the mouth. Using knife as a fork. Even though some normal people do that. Right? Preservation of a specific component of a task. They try to mail a letter and they keep folding and folding and folding, never able to put it in the envelope and seal it. Keep folding and folding and folding and folding. These are the ways in which ideomotor apraxia presents. This is what the patients will come to tell you. Examples. You have to now put it as, you have to make a diagnosis. Ideomotor apraxia is not a diagnosis, it's a clinical symptom. But nobody will come to me and say, you know, I think my mom has ideomotor apraxia. No. They will tell you what is going on. You have to now figure out what the ideomotor apraxia is. See how construction apraxia presents. You show a patient a line, but this is how you can demonstrate it, right? You show a patient a line, you say divide that line into two. And because he's not able to see the other half of the line, he divides the line into two and then divide it into the half he could see, he recognizes into two. So this is how he will divide this line into two. Or you show him a piece of paper with a bunch of lines, and you tell him cross out all the lines. And because he's not registering this section, he's going to cross it only on this side. Right? Or you tell him, draw the face of a clock, and he will scrap everything on one side, totally ignoring this side. How does this present in the clinic? the most remarkable one that I see was when a stroke patient on admission will not eat. They put the food in the morning, put the breakfast, they'll come in the afternoon, remove it, and put lunch. He won't touch it, he won't even touch it. He's not blind, he's awake. So he won't see it, he won't touch it. Dinner, they come, remove the lunch, put it in. And then the neurology attending came one day. And this is like, now we're having conversation about should we put NG tube or G tube for this patient to feed the patient because he's not eating. And the neurologist said, put the food on the opposite side. When we put the food on the opposite side, the guys are eating. Because information from that half space the information was there, but he was not recognizing it. So when the food was on the left side, he was not seeing it. It's there, he sees it, but his brain doesn't register it. So we have to now change this side where we put the food, and he started eating, and we didn't need to do any surgery. That is how hemispatial neglect, which is a manifestation of construction apraxia, presents. The good thing is that it is not very common, because in most people, both the right and the left hemispheres are represented on both hemispheres, right? Even the left-handed people, right? So generally speaking, the right hemispatial neglect is what is more common, right? So, but this is how it will present, right? And you will figure this out when you tell the patient to draw the face of the clock, right? Acalculia. I want you to remember that both construction apraxia is a manifestation of lesion in the parietal lobe, right? And ideomotor is a problem in the premotor cortex, right? Don't forget that. Acalculia is inability to calculate, right? You remember we did the serial 7 and serial 3 subtraction and stuff like that. But I want you to remember that there is a term called dyscalculia. Dyscalculia is a developmental equivalent. It's a developmental disorder. You see this in children when they are growing. They're not trained in mathematics. They hate mathematics because they have a developmental problem. Okay? Acalculia can be primary, that is, it can occur by itself, but many times it's a part of a neurologic deficit. And you can see it with amnestic syndrome, Gerstmann syndrome. And Gerstmann syndrome specifically is a constellation of acalculia, digital anomia, so the person cannot count numbers. That's a digital anomia. Agraphia, they cannot write. And then they have right-left confusion. And I'll tell you what causes Gerstmann in a minute. But whenever you see acalculia, you have a problem in your angular gyrus. Okay, just remember, angles and algebra and geometry, they're all calculation stuff. Okay, so acalculia is a manifestation of angular problem in the angular gyrus, which is part of the PLN, the peripheral language network. Okay, agnosia, inability to recognize and register familiar faces, voices, sounds, colors, touch, and texture. So agnosia is the big name, but depending on what the patient is agnostic of, we call it visual agnosia because they are not able to recognize familiar faces. They see their children, they can't recognize them as their children. One man shot his wife because he thought he was an invader, right? Auditory agnosia, they can't recognize their voices. Somatosensory, you give this person cotton wool, you cannot tell a cotton wool from ice. Okay? Prosopagnosia, specifically for familiar faces. Phonagnosia for familiar voices. These are persons, these are environmental. So we call it auditory agnosia if you cannot recognize the hood of a car. Papa, papa. So sometimes you're driving, right? People are walking across the street. It's a crosswalk, right? And they're walking and and you say, papa, papa, and they just look like this. Don't get angry. Sometimes that could be the way somebody with auditory agnosia will present. Right? So when it's an environmental sound, we tend to use terms like visual agnosia, auditory agnosia. When it's a face, a family, a person, we talk prosopagnosia, phonagnosia. And then social emotional agnosia. They hurt people and they don't even register it. You know, you see some people, they will do things that obviously will annoy anybody, but they can't register it as annoying. Right? And type of thing, you're so mean-spirited. Sometimes, oh, grandma just became so mean recently. Grandma may be sick. Okay? So it's called social emotional agnosia. And then you have cortical achromatopsia, which is agnosia for colors. Right? Whenever you have agnosia, something is wrong with your occipitotemporal network. Most of the time. And to a lesser extent, there's so much sensory context and corpus callosum. But most of the time, it's your occipitotemporal network that has the problem. Okay? Then, so that is all about agnosia. Let's talk about amnesia. Inability to retain and retrieve memories. That's what amnesia is. You can't retain and you can't retrieve. Right? Sometimes it's part of normal aging, but it's a major symptom of Alzheimer's. Well, we call it Alzheimer's, but it's supposed to be Alzheimer's, right? So, you need to be able to tell amnesia of normal aging from Alzheimer's disease. And these are very important differences. I really like these differences. In Alzheimer's disease, patients forget whole experiences. In normal aging, they forget part of the experience. They remember there was a wedding, but they can't remember who was there. Alzheimer's disease can't even remember there was a wedding. If you give a normal aging patient with amnesia time, they're able to remember later. Alzheimer's patients, they don't come back to remember. Normal aging people with memory impairment, they can use notes and reminders. Old-timers, they can't. Whenever you have memory problems, something is wrong with the limbic system. Okay? So, these are all these regions and what they do. Now let me see how much of it you've been able to retain. In this table here, which I believe is the last thing I'm going to talk about, or one more thing. So in this table here, I have a list of responses on the mini-mental status, right? I have regions of the cortex, or the dysfunction actually, and I have regions of the brain. So what I need you to do is, for this motor response, I want you to tell me what is that dysfunction called, and which part of the brain is it related to. Alright? And I'm going to go by name. And I'm going to start with Hera. Alright? So, Hera. This person cannot do serial 7 subtraction. So this person has acalculia. And that means we need to look at the angle gregarious, right? Remember I said angle, geometry, algebra, and mathematics, right? Okay? That is a good one right there. So serial 7 subtraction, acalculia, pay attention to the angle gregarious. Alright? Okay. Justin. This person is unable to recall the names of 3 objects. It's not able to recall it. The names. Inability to recall. Inability to recall. In other words, you can't remember. Okay, that is amnesia. So where should we look? If somebody has amnesia, we look where? Does your class agree?
Yeah. Yeah.
Okay, let me write this thing down so we don't argue later. So, you say A7
F.
7F.
B 5C.
I say B.
5C.
5C. Good. Right. So, Brad. No. Christian. Inability to name two objects.
Visual agnosia?
Name.
Or name? So it's going to be broken aphasia.
Name. To name. What is it called? First of all, what cortical dysfunction are we talking about? The patient cannot name. So you show him a pen, say, what is this? He can't name it. That is anomia, right? Christian, is it anomia or not?
Yes, anomia.
Okay, so if it's anomia, which region are we going to be looking at?
We're going to be looking at the temporal lobe. No? Parietal lobe.
No. Anomia is the common finding in patients with aphasia, which is a manifestation of problems with a network, right?
Perisylvia network?
Okay. Does the other class agree? No? Any dissent? So tell me, to name two objects, C, 1, G, right? Okay. Ashton. Inability to repeat no ifs and or buts.
Broca's.
Thank you. That is Broca's aphasia, right? And where is that?
Temporal lobe? Frontal lobe?
Frontal, exactly. Inability to repeat no ifs and or buts is a D, right? You say it is Broca's 6, and it's got to be in the frontal lobe, right? All right. Mel. Inability to follow a 3-stage command. Ideomotor apraxia. Good. So, inability to follow a 3-stage command is E. And you say it's ideomotor apraxia. And where is the problem? Huh? Premotor cortex. Okay. And premotor cortex is D, right? Okay. Wendy. Inability to read and obey a simple written command. Good. Wernicke's. And Wernicke is number 3. And where are we going to look? Temporal B. Good. Excellent. You're doing really well as a class. Vinny. Where is it? 11. Okay. All right. Justin. Inability to copy two intersecting pentagons. G. Exactly, that is construction apraxia. Where are you going to look for that? Copy. You have to be able to see it. Thank you. Occipital-temporal network. Right? Good. Inability to recognize and or describe familiar objects.
Wait, why would
Visual acres.
How come apraxia wouldn't be the parietal lobe?
How come what?
Construction apraxia. Why wouldn't it be the parietal lobe? Because it's like hemispatial neglect.
Yeah, hypoxia.
Wait. Inability to copy intersecting triangles is really construction apraxia, is correct?
Yeah, because visual agnosia is the occipital temporal.
You're right.
Yeah.
Okay, so G4E, right?
Yeah.
Okay, good. Thank you, Ali. All right, so the last one, you already got that one, right? Visual agnosia and everything aligns in that one. So, I mean, am I going to test you on this, into this level of detail? No. Yeah. It's just for you. It's just something I want to use to drive home the point. When we start talking about dementia, you will see that we use this information to figure out the type of dementia somebody might have. Okay? Now, some guys in Canada, they came up with a Montreal Cognitive Assessment Test.
It's 2 or 3.
Stop bugging me. Right? They came up with this MOCA. It's called Montreal Cognitive Assessment Test. Because, you know, when you do mini mental status, you have mild, moderate, severe. And if you look in the studies, more people with dementia fall into that mild stage. So people in Canada thought that we need to be able to separate in the mild category some kind of a severity scale, right? So they came up with this Montreal Cognitive Assessment Test. A little bit simpler, but very similar to Boston. I'm stuck in Boston because the guy is Californian from UCLA. I'm a faculty at UCLA. I'm not going to train Boston from OCA, but I'm just putting it there so we know that there is something called Montreal Cognitive Assessment Test. It's out there. Some people use it, and you will be surprised if you find yourself in practice and somebody uses it. Any questions? Question? No, okay, I'll see you at 2:30. Are we clear now?
Nothing has entered my brain in the last 3 hours. Nothing new.